Our next topic is EDOF Try Today's Best Is It by Dr. S.K. Mitra from Jharkhand.
Good morning, everyone. It is heartening to see almost half of the hall are free. I mean, hall are full with in the early morning of today. So, I'll be talking on some technology. I've got no financial disclosure to make, and I'll talk purely on my personal opinion and personal experiences with evidences. Now, whenever talk about the implantation of something, implantation of any of the lens, we always talk about the spectacle independence. And the common question of the patient asks to a doctor is, "Sir, बाद में चश्मा भी पहनना पड़ेगा?" This is the most common question. So, the lens we are having today, there are limitations, but the newer technology is coming in the market. So the limitation of the conventional trifocal, I'll be talking about the trifocals. Due to their design properties, all conventional trifocal IOLs inevitably reduce the contrast sensitivity and the generate photic effects. The solution is to blend EDOF with trifocal. The lens combining trifocal technology with EDOF optics provides continuous range of vision from distance to near, uses diffractive rings on the optics similar to the multifocal IOLs. It combines diffractive multifocal and diffractive EDOF technology both. Now the extensive literature search shows that the extended depth of focus versus tropical trifocal and intraocular lens implantation is a meta-analysis which conclude that the trifocal IOLs improves uncorrected near visual acuity compared to the EDOF IOLs. Uncorrected distance and intermediate visual acuity, halos and glare were not statistically different between both the groups. This again leads to some the search again what to do to reduce the contrast sensitivity, reduce the light energy loss. Now if we look into the conventional trifocals, there are diffractive elements and also called this kinoform, or in simple language it's called the ridges. The trifocals are basically fusion of the bifocals of two different additions like plus 3.5 and 1.75, and these are the heights of ridges you can see. The concept of the kinoform is a type of diffractive optical element often used in lenses that manipulates light waves to achieve specific optical effects. The height of the plates ridges is usually tailored around the wavelength of light milestones to the human eye, which is around 550, it is 546 actually, the nanometers. Now the effect of ridge heights is when the height of the ridge matches the wavelength of light, all the light is directed for the near vision. When the height is half of the wavelength of light, more light is directed to the distant vision, and if there is no ridges, all light is directed for the distant vision. When the ridge height is half the wavelength of light, the energy distribution is 40, 40 and 20. Now these are the apodization, widths and space are the control of powers, and height control the energy split. Now this everybody knows that I'm not going to the details to explain the technologies. But the design of trifocals, different trifocals of comprehensive understanding, these are the trifocals with these are, for example, panoptics, and this is non-apodized, and apodized is gradually tapering actually. Now search results that the clinical outcome of a new diffractive trifocals intraocular lens with enhanced depth of focus. These are the combined EDOF with tri. Now the new trifocal EDOF provides visual improvement of far intermediate near distance with a high level of visual acuity. I'm talking about the 4 years back actually. But this lenses, that time this technology was not there. The new technology, new approaches has come in and uniform apodization of stretched the super Gaussian profile in non-symmetrical fashion as function of the radial distances. Now see the wave-based design, free of sharp edges of the ring in the lens, and supermoon edges of the optic surface provides no iris shaping, help to reduce halos and scattered light. Phase apodization again enables high balanced light energy distribution to near and intermediate in mesopic, scotopic as well as photopic conditions. See that this lens comprises of the energy distribution and the total loss, and there is no loss, almost the loss is negligible, and in case of the previous, the normal trifocals, the conventional trifocals. So EDOF tri gives the light distribution, this the loss of energy is very, very minimum. We achieve next milestone of energy efficiency of light distribution resulting in minimum light loss in comparison to the other trifocals. These are the defocus curves. Now there are the highest energy efficiency, crystal clear vision, adaptability of light conditions, perfect energy distribution and wide MTA peaks. All peaks features wider zones of the diopter, provides excellent extended depth of focus for the enhanced vision. Now these are the there are super smooth edges of optic surface. Phase operation enables high balanced light energy, and the lens has 3 diopters. One is and add of 1.5 and 3. So this is a small clip of one of my patient. This is a high myopic patient. You can see the after cataract development, this patient got medically unfit and he's developed the squint. The biometry shows it reads actually plus 11 diopter of lens. There are 2 cases. One is 11 diopter, one is 9 diopters. So after the phacoemulsification, the simple injector system is Boston-Lomb injector like same as Boston-Lomb injector system with a butterfly cartridge. This is 11 diopter lens. The lens is coming in the blister format packing. So just push vertically, that the lens will free from the package. So place it in the cartridge. It will go through 2.2 millimeter incision site. You can have an wound assisted or you can have direct insertion at 2.4. But it will go through 2.2 incision.
Dr. S.K. Mitra?
Yes. So this is the
one moment,
post-op vision of the patient, post-op pictures, and patient is reading N5, N6. I mean 6, 6, and 6.
Good.
So in conclusion, treat the patient as per the requirements, should not be the biased decision and follow blindly. Patients should be provided with what is the best in today's scenario. Proper planning and execution of surgeon skill is important. For spectacle independence, when the patient asks for spectacle independence, you should think about the EDOF tri. It's a very good option. Thank you. Thanks for your patience hearing.
A quick comment from the panelists. They want to add anything? Yeah.
I have an objection. What was the age of your patient?
The patient age is 46.
Have you seen the retina? You're putting a trifocal. He's got a long life.
Yeah.
It's got a long life. I do not personally
Yeah, for the
to it. I don't know what Kashyap will say, but
for the scarcity of time, I could not show those OCTs
No, but-
and fundus pictures.
but could be. But what happens after 10 years to him? He's got a long life. It's a very difficult situation. A high myo especially is prone to retinal disorders. Why are we going to put him in a trifocal?
Before doing such cases, you have to examine the retina thoroughly, and if there is no problem, then you go ahead with this.
Yeah.
But you know, they are always prone to certain retinal disorders, and seeing retina in a trifocal and doing work is very difficult sometimes.
But the pre-op check already has done. It's actually I could not this sparsity of time I could not place those things. OCT and retina. Yeah, patients is
Sir,
coming back.
Sir,
regularly.
Dr. Kashyap, I think it's a relative contraindication. Basically, high myops trifocal. It's not an absolute contraindication, but it's a relative contraindication because of the subsequent changes that may take place. Anyway.
But
Preoperative considerations and examinations are okay, but what we say is in high myopes, it is not only before the surgery if the retina was okay. After the surgery, later on things happen because of the changes in the vitreoretinal.
We should avoid, I think, doing in myops.
So I think that should be.